Thank you very much, Martin, and good morning to everybody. So I'll give you my experience in adding the adipose tissue to the static, to the normal AMIC technique, what I defined and called, it's just published, the lipo-AMIC. So you have just seen it. The AMIC is the most studied smart scaffold for cartilage repair. It's a one-step procedure, no cartilage harvesting, no donor side morbidity, and that's important, no in vitro cell expansion. So it's giving good results, but you know that we are always as surgeons looking to get something better. And over the time, several augmentations have been proposed, from the PRP to the bone marrow concentrate to the adipose tissue. And getting in the adipose tissue, we have to ask ourselves, why is autologous fat grafting successful? Mainly two reasons. Because we have the paracrine and undifferentiated cells present in the stromal vascular fraction, and then thanks to the mature adipocytes, that during degradation they secrete important protein factors that, as we've seen yesterday, stimulate the attached adipose progenitor cells. So we have to start thinking to adipose tissue as a real organ, as a real endocrine organ, and so it's what it will be called the adipose tissue complex. The adipose tissue complex, as I just said, it provides an important part of cells, an important bioscaffold capable of encouraging adhesion, cellular adhesion, and important paracrine functions. When we get to see the stromal vascular fraction, you certainly know it's a mix of cells. Mainly the most important one, thanks obviously to the work also of Professor Kaplan, are the MSCs and the pericytes. But also the mature adipocytes are very important because they have their attached progenitor cells, what they are called pre-adipocytes. Still, once more, the 3D extracellular matrix bioscaffold contains fibroblast and mainly perivascular elements. When we have arrived to understand all of this some years ago, we understood that it was possible to start doing the transplantation of the adipose tissue complex in a non-manipulated way. As I told you, also the mature adipocytes are very important because they secrete important signals that stimulate the niche progenitor cells attached to every adipocyte and to become metabolically active. So what we know now, that what's happening is we have an improvement in the microenvironment, and this will give rise to a regenerative function while preserving the immunologic integrity and providing important anti-inflammatory responses. And this, as once more Kaplan said also in his previous paper, in the last paper he's just published in 2017, has brought to define the pericytes as the precursors of the mesenchymal stem cells. And now you know we have to call them medicinal signaling cells. And these medicinal signaling cells secrete bioactive factors, are immunomodulatory and trophic, and the factors that have been secreted activate all resident stem cells to reconstruct the new tissue. This is the new paradigm from Kaplan. In fact, the infused MSCs home on active vascular site of injury and secrete bioactive factors. Going to the clinic, what happens? That we have been able to get what we knew for the research, basic research, just when we were able to understand that we didn't need enzymatic systems to obtain the tissue, but we could obtain it by filtration and process and microfragmentation processing. And so this enables us to have two things: cell populations and native structural fragments. So no chemical and enzymatic digestion of the stroma to obtain separation of the very extensive cell-to-cell and cell-to-matrix connection. And at the same time, we obtain small particle size cells containing bioactive adipose matrix scaffolds ready to be used. As you know, you can use them just an injection therapy or through small needles, or then you can also use them, as I'll show you in my technique, in cartilage repair procedures. And it's also last important to remember and underline the fact that we are keeping in this way the stroma, the normal stroma. And this maintenance and development of the cellular attachment favor the activation and proliferation changes within the transplanted biocellular matrix by placement of many MSCs and stimulating early cellular activation, proliferation, and response to site-specific signaling proteins. And so we can move on with the healing cascade. This biocellular modality has been proven, as you know, for several applications, but in our interest, obviously, in musculoskeletal disorders. And you know that when we tried, if you go on the literature and see how the adipose stem cells have been used in orthopedics, you can use them, as I was saying, as injection, and it's from about 5 years that are published very good starting animal studies results, but also on biological advanced scaffolds. And we have to get deeper on the use of scaffold, because as you see in these papers 10 years ago, they were stating that adding adipose stem cells to various scaffolds led to the filling of chondral defects with reparatively aligned cartilage that consisted of significant amounts of type 2 collagen. But in contrast, when scaffolds with no adipose stem cells display lesions filled with fibrosis at follow-up, this means that clearly stated the benefit of adding adipose stem cells on a scaffold. But that's just what it came out in the last years on the papers on the adipose stem cells. And if you go and check them, you shall see significant improvements in pain and function scores, both in injection and both in the use on scaffolds. So what you knew from yesterday, it's the introduction on the market of this system, the LipoGem process kit, that has given us the possibility to apply what Professor Kaplan studied in the basic research clinically. Because in this case, adipose tissue is just gently microfragmented, it's just by mechanical forces, and it's washed from pro-inflammatory and oil blood residues. And you also obtain pericytes retained within, and that's very important, an intact stromal vascular niche, being ready to interact with the recipient tissue after transplantation, and thereby being able to become mesenchymal stem cells, or MSCs. The MSC's activation entails the release of regenerative factors, which make the transplanted product act as a timely releasing medium. Let's get to the part that maybe certainly it's more interesting for you, what I've defined the lipo-AMIC technique. I've separated the two steps. The first step, obviously, is the adipose tissue transfer by a very little lipoaspirations. These are the steps I'll show you after some videos. You just start outlining, preparing and draping the donor area. You can use just a needle, 18-20 gauge needle, to create epidermidis and dermis opening. Then you reach the subdermal fat below the scarpa's fascia. You enlarge the opening. You introduce your infiltration cannula, and you distribute the tumescent fluid. Then you do what's called the pre-tunneling in order to facilitate the withdrawal of the adipose tissue. You connect a luer lock syringe to the harvest cannula, and you just move up and down, forward and back the cannula, and having applied the vacuum, you are able to obtain the adipose tissue. Let's have a look to the procedure. Up in your left side, you're seeing what I'm just doing, a needle opening, very smoothly, very easily, through the epidermis and the dermis. At that point, you just enlarge the opening, and through the enlarged opening, you are able to introduce the cannula, as you see, and through the cannula, you will start the movements and you start introducing the fluid that will enable you to have the fat withdrawal. Then, just as I told you, to make things easier, you will, at the end, when you have ended introducing the fluid, you just start doing some movements with the infiltration cannula, and this enables you to have a very easier withdrawal of the fat because you are detaching the tissue, so it's coming out very easily, and you feel it really easily. Even I'm not obviously a plastic surgeon, I'm doing it by myself, it's easy to learn it. And at the end, you do the fat withdrawal slowly. You have to keep, as correctly the plastic surgeon obviously said yesterday, you have to keep it in a good plane. Do not risk to go too deep. That's the main issue for everybody of us. Very slowly. This is really accelerated in the video. The movements are more slowly. You keep it in your fingers and you slowly move in the same directions, up and down, continuing to obtain the lipoaspirate. As you see, the syringe is practically filled up with the adipose tissue. It just takes maybe 3 minutes, 4 minutes, not more, because you know that we have a low amount. We are looking for a low amount. Then, once more, you can use it as an articular injection. That's a simple procedure. You do your dermis and epidermis anesthetic infiltration, and then you just introduce it. I'm using the lateral compartment, as you see. There was the discussion yesterday on what access. I prefer the lateral compartment. It's easy to fill it up. You see, it's very, there's no resistance, so the infiltration is quite easy. And then obviously I retain, very important, doing some raw movements in order to diffuse the fat inside all the joint. And this is obviously the easy use in articular injection. But more interesting for me, what I call the lipo-AMIC. This is the second step of the surgery. Just to remember you have the liposuction. This is the beautiful shaking from the lipogems system. You obtain the concentration of your tissue. Then in the pictures, you can see obviously what you obtain at the end, the adipose tissue. This is the chondral guide membrane, collagen type 1 free membrane that you will see. Obviously, you are going to cut, and you saw from the other speakers. You soak the membrane in the adipose tissue, you leave it there for 10 minutes, and then you repair the chondral defect, osteochondral defect. Once more, some videos, what I'm doing. You already see, I've already done the debridement of this defect. I'm adding the adipose tissue just by the syringe. That's the first step. Very easily. Once more, while I'm doing that, I told you the cut membrane, I'm not going back to the AMIC steps, you know that. The cut membrane is soaking with the adipose tissue. It's left there, I think, about 10 minutes during the rest of my surgical steps. In the meanwhile, you see, I check it very well. Then I apply the cut membrane on the previous tissue I put on the chondral surface defect already debrided. I add some fibrin glue, and I'm checking to close all the openings. As you see, I'm putting the fibrin glue just up on the defect. Then I'm applying once more the adipose tissue on the fibrin glue in order to have a double application, if we want to say it, or triple, because obviously the membrane is soaked in the adipose tissue for that period. And this is the last image of the chondral repair once it has been terminated. It's just published what I told you I defined The lipo-AMIC is just published in these days on the Italian Journal of Orthopedics, and it refers to the experience of my first 18 patients. You can see mainly that all the scores are going beautifully. One thing I want to underline, the fact that what you find is that already at the 6-month follow-up control, the patients absolutely are out of pain and have the functional scores are really good, even better of what the traditional AMIC experience I had before. Once more, I'll show you a complete case, a large defect of the trochlea. These are the surgical steps. I won't annoy you anymore repeating them. I was lucky to have the second look follow-up at 2 years, and these are the histology with a clear hyaline-like cartilage, and this is the good repair also in the 24 months post-op MRI. So let's go to the home messages. Clearly, the AMIC technique is well known, is safe, is cost-effective, is minimally invasive, is based on the use of this double-layer collagen type 1 and 3 membrane. The collagen, you know, obviously, it's a native biological material, excellent tissue compatibility and little toxicity. The chondrogyne membrane, it has been proven, as you saw before also, in several also work on animals, also from Justus, that it influences the chondrogenic differentiation of MSCs and stimulates chondrocytes to enhance proteoglycan deposition. But this, we need also to get deeper in this. Already you see this work from Martin. It was 4 years ago. He presented it, comparing the chondrogyne to other scaffold, the PGA scaffold called ChondroShield, and the YALOFAST, that it's obviously a hyaluronic acid one. And as you can see, the incorporation of the MSCs was greater in the chondrogyne. And this maybe was due to the factor that the scaffold structure, obviously collagen type 1 and 3, was more pro-adhesive compared to the hyaluronic acid and to the polyglycolic acid of the two other scaffolds. And there's been also another paper for the group of Coley in 2015 where they made a...
Same paper.
Yeah. Yeah?
Yeah.
Second, I didn't know that. Well, they demonstrated that a greater number of viable MSCs were adherent and incorporated into the chondrogyne, and also that the cartilaginous extracellular deposition was most marked in chondrogyne than with bone marrow MSCs. So, biomaterials are important and determine cell distribution, cell differentiations, and also graft biology. Now some home messages about the adipose tissue. It's clearly abundant, easy access, is good source of MSCs, no need for cellular expansion or enzymatic use, as you saw with the new systems. Adipose tissue complex provides concentrated cells and the important bioscaffold extracellular matrix. These magic signaling cells also stimulate the own resident stem cells to reconstruct a new tissue. And Lipogem is been defined as an active preserved tissue graft that can be used in outpatients, both as injective and as a scaffold, without using enzyme, additives, or separate centrifugations, just relying on the use of mild mechanical forces, because what it does, it really supply a regenerative environment, and this has been proved. Another important fact, the lipogems have had the FDA approval because it's autologous, minimally manipulated, intended for homologous use, enzyme-free, not dependent on the metabolic activity of cells for its primary function, and not combined with any other type of things, just and saline. And it has been published already some good results on it. This is my final summary statement. Our study clearly confirmed the effectiveness of the procedure that we developed and called lipo-AMIC, in which we added microfragmented adipose tissue containing pericytes and MSCs retained within an intact stromal vascular niche with high regenerative potential and optimal handling, together with a collagen membrane capable of retaining the cells in situ and promoting the chondrogenic transformation. As you saw from the results, the lipo-AMIC allows obtaining significant clinical improvement already from the 6-month post-op, earlier than the standard AMIC. Obviously, we need more paper, more studies, longer-term comparative examinations, and certainly I do believe that the future obviously will be more in proteins and cells and not in metal and plastic. And I also think that meetings as this one are very important to exchange the ideas, get new approaches, also through nice martinis drinks in the night as yesterday. Thank you very much.